Jeet, good morning. You can start your presentation.
Sir, is my screen visible and am I audible?
Yes, yes.
So, good morning, everyone. My today's topic is the arthroscopic cuff repair, various techniques, merits and demerits, and what are the factors that gives us the good and effective cuff repair technique. So, today's discussion will be over those following topics. First, the factors for tendon healing, the arthroscopic portal that are essential for a cuff repair, extent of mobilizations, how we can mobilize the cuff tissues to get a good tension-free repair, the tear morphology and the tear-specific repair techniques, how the repair techniques has been evolved from a single row to a double row, and latest transosseous equivalent techniques, and what are the recent modifications, and at last we can compare the different techniques on the basis of the outcomes. If we see what are the variables that influence the healing between the tendon and bone, they are if we characterize over the what are the most important to least important, these are the contact area and the pressure of the repaired cuff tissue over the footprint, the tendon bone interference motion, the repair strength and the stiffness at the day zero level, the tissue and bone quality that are going to help the anchor position in its original region, the biomechanical factors for the healing. This more or less constitutes the most important factors for healing. Article published by Park et al. At 2006 compared the different techniques over the pressure created at the footprint region by the tendon repair. Now, image 1 is the transosseous equivalent repair technique, which shows a uniform level of the pressure distribution over the footprint area, whereas the mattress and the double row or single row technique concentrate the pressure over a single point. Hence, the chance of re-tears are high in these following two categories, whether the transosseous equivalent being a uniform pressure distribution theoretically proves a better result. Moving to the next point, tender bone interference motion. Ahmed et al. Published this article 2002 showed that the repair which produces a less motion at the tendon to tuberosity interference produce a superior result than the other techniques. Considering the repair strength, there are multiple articles, mostly at the biomechanical comparison of the cadaveric bed study regarding single row, double row, and transosseous equivalent technique. Most of them have been depicted that the initial day zero repair strength, the footprint reconstruction of the rotator cuff, shows it has a pivotal role to dictate how much the repair construct is strong. So if we compare this biomechanical study by Park et al., we can see that the transosseous equivalent technique shows the initial stiffness, linear stiffness, hysteresis, everything better than the double row or the single row repair technique. Last but least, the last point, the tissue and the bone quality. The tear includes the tear size, fatty degeneration, suprascapular neuropathy, muscle atrophy, tendon delamination, tendon retraction, location, and stiffness. These factors to be considered while choosing the particular technique while making the cuff repair. Another set important mechanical variables are gap formation after the repair, the load to failure section, repair tensioning, the tendon vascularity, and the footprint coverage. Highlights over the tendon vascularity, if you're going through a single row or a double row, the number of knot that you are using over the area of the footprint, that decreases the localized vascularity and actually detrimental. So that we have to adapt some technique where the number of knots should be less, but the load to failure should be much higher. So that's the idealistic situation. The article by Park again showed the possibility of re-tear increases when the tension increases more than 35 Newton. So our repair technique should include an optimum level of the load to failure method. Coming to the next section, portal placements. The most important portals that we use for the cuff repair are the posterior, anterior, and the lateral portal. For the working And the station portal, we have anterolateral, posterosuperior the Grand Canyon portal, the anterosuperior portals. This picture is taken from the Kims et al., who one of the most first article showing the positioning of the rotator cuff repair portal. This is the posterior, anterior, the mid-lateral portal, and the anterolateral portal. The new technique of three sister portals for the massive rotator cuff tear got some importance. They have provided data that the subclavian portal that is made superior to the clavicle, Nevischart's portal that is made above the soft spot between the clavicle and the acromion, and the posterior infraspinatus portal. These three portal has some distinct advantage. First, being the landmark is very localized to the scapular spine, which is prominent after the insufflation of the joint. It is very easy to identify, so this portal position cannot be missed. After making these three portals, also they have found they have a very less fluid extravasation, and no rotation of the shoulder is required to see the to the anterior to posterior most of the cuff region, and they are safe. No neurological structures comes near to this portal. Other than that, the posterior, Grand Canyon, and the lateral portal has been mentioned in this article. We can see that using this probe, we can reach up to the posterior. Using the subclavian portal, we can go directly to the anterior. And using the Nevischart's portal, we can go directly to the mid part of the repair. So all anterior to posterior huge cuff repair can be tackled in this technique. Moving to the most important section, cuff mobilization. If we do not debride the edges of the cuff properly, we do not prepare the footprint area of the bone, and we do not enough mobilize the cuff, it creates a high tension, low biologic repair with a high chance of the failure. Cuff mobilization includes a couple of important and interesting points. First, the superior capsular release and the rotator interval coracohumeral ligament release. Both the technique allows up to 1.5 centimeter increase of the tendon extension. Now, what is important regarding the rotator interval technique? Our method is to recreate the pouch that is normally present superior to the glenoid labrum between the undersurface of the rotator cuff and superior or posterior superior portion of the lateral aspect of the glenoid neck. It can be from 2 to 10 o'clock position. It gives around 2 centimeters of extra mobility in the cuff. We should not violate for more than 2 centimeters because there's a high chance of neurovascular injury. This image shows that for the mobilization purpose, the scissor has been the location is just between the supraspinatus and rotator interval, just superior to the biceps tendon attachment. And later, an arthroscopic scissor is using to make the interval clear. Another two important aspects are the anterior interval slide and the posterior interval slide. Anterior interval slide technique is depicted by Tetro et al. They follows this following landmark. The direction of the release should be following the coracoid. The portal to be used is the accessory lateral portal. The starting point should be anterior and medial to the biceps root, like we depicted here, anterior and medial to the biceps root. Plane should be used is between the rotator interval and SSP. So you can see there is the supraspinatus and the rotator interval. So we should release in this plane so that we get an extra mobility of the cuff. End point will be until the base of the coracoid is exposed. This is the anatomical cadaveric study showing the position of the CA ligament. This is the CA ligament, and this is the coracohumeral ligament. So coracohumeral ligament is actually below the CA ligament. So when we are releasing this coracohumeral ligament and rotator interval, the landmark should be up to when we reach and see the CA ligament. This gives us approximately 2 to 3 centimeters of extra mobility of the cuff, basically over the anterior section. What is the posterior interval slide? If we see the supraspinatus infraspinatus, they originate at different position, but when at the point of their convergence, they show a common sheath which is constitute of both supra and infra tendon. But there is an interval present between these two muscles known as a posterior rotator interval. If the massive cuff repair, the cuff is not coming to its original position, we can release this interval. The landmarks for this thing is along the scapular spine. Portal, most commonly used the posterolateral or the posterior portal. End point should be till the fat pad is seen, because when the fat pad is seen, that means the suprascapular nerve is very nearby, or we are very near to the notch area. The plane that we use is between the SSP and the ISP, and the maximum mobilization possible is between 2 to 3 centimeter. There are various articles showing the pros and cons of the posterior interval slide, but this article published by Miller et al. Shows the approximate distance from the spinoculanar notch to glenoid rim and rim to tendons and the confluence of the humerus insertion. Depending on the factors or depending on the sizes, we can estimate how much you should go for the mobilizations. Moving to the next point, the various structures, the various type of the tear and how to manage this thing. The article published by the Davidson and Burkhardt at the year of 2010 published in Arthroscopic Association of North America, they divide this thing into 4 types: the crescent, longitudinal, massive contracted, and the cuff tear arthropathy. When describing the crescent and longitudinal, they have used 2 parameters. One is the L for length and W for width. On the MRI, the maximum medial to lateral length on the tear, that is depicted as the L, and W is depicted as the maximum AP diameter or width of a tear in the T2 signal oblique MRI. So in case where there is length is less than width and length is less than 2 centimeter, that predict a crescent separate the tear, the first criteria by the Burkhardt. Second, if we get a length more than width and the width is less than 2 centimeter, it predicts a longitudinal type of tear and side-to-side convergence is to be done. So length more than width is the second type, a longitudinal like a L or U-shaped of tear. For ideal situation, crescent is good managed by the end-to-bone repair technique with a good to excellent result. For the longitudinal tear, margin convergence technique that we will discuss after some time, that is the most effective technique. For the massive contracture with the long and wide, which are more than 2 by 2 centimeter in both AP and the mediolateral direction, the interval slide at the partial repair are most comes handy. This techniques has been further described by Peter Millet et al., who classified this technique according to their outcome. Crescent shaped tears has 40% full thickness tear. It has a good mediolateral mobility, hence direct attachment to the tendon to the footprint is possible. The method that he has told to be done is a single row, double row, or the transversal equivalent. All 3 gives a good result. For a small tear, single row gives a good result. For the massive tear, you can consider regarding the double row or the TOE tears. For a U-shaped tear, which has a good mediolateral component than the AP component, they extend more medially and the less common. They have the less mediolateral mobility. Hence, if we forcefully pull towards the attachment section, there is a high chance of the failure because of the great tension, increase in the tension. For them, the margin convergence technique or the side-to-side sutures are the appropriate. After side-to-side sutures, the rest of the part we can put over the footprint. So this is the example. If this is a crescent-shaped tear, what we can do is directly put the tear over the footprint. If it is a U-shaped tear or the longitudinal tear with a great length, here what you have to do is to first make a side-to-side repair known as the marginal convergence. Then it is converted to a crescent-shaped tear, which can be repaired by using a bone to tendon attachment. Next type comes the L-shaped or the reverse L-shaped tear. They constitute around 30% of the rotator cuff tear. L-shaped tear is told when the longitudinal arm is going through the anterior interval between the subscap and the supraspinatus. And the reverse L-shaped tear is told when the arm is going between supraspinatus and infraspinatus. The tearing occurs through the both intervals. We call this a tongue-shaped tear. The repair technique for this is to first address the posteromedial to anterolateral direction for L-shaped tear and anteromedial to posterolateral for a reverse L-shaped tear. Like we can see here, this is a L-shaped tear. What we did is to first to close the longitudinal arm by starting from the posteromedial to the anterolateral. After repairing that, we can only the crescent shaped tears remaining, which can be fixed from bone to cuff technique. A temporary reduction stitch can become very handy to get the end or the apex part so that the tension can be approximated. Complex tear is that when there is a low tension is a tear where there's a multiple variable can be present. For them, the low tension repair, medializing of the footprint, and the good approximation tendon to bone is the estimated thing. We can see there is a massive tear. How to manage this thing here shows that this is the posterior interval slide made between the SS and the IS and the anterior release, which gives some extra mobility of the cuff. Then the cuff is fixed over the tendon to bone area. And then the rest of the part is sutured by the marginal convergence technique. Moving to how the repair technique has been evolved. At 1990s, when the repair arthroscopic start popularizing, everything we are doing on the single row repair technique. If we see, the anchor positions were much more lateral, near the lateral edge of the footprint and the proper medial location. This gave us the idea that if we put the lateral anchor more laterally, the increased area of footprint coverage will be there, which will give a better bone to tendon healing. But we see after the 1990s, we see a lot of failure at the re-tear of the single row. This single row failures actually evolves into it gives us a result into three different way of thinking. First, changing the suturing technique like a Mason alley or the ripstop technique. One group of surgeons, they move towards the medialization of the footprint to impart a less tension on the repair, plus passing the suture on a more healthy musculotendinous junction than going to the more muscle part. And third group of surgeons who started to do the changing the whole repair technique by the changing the anchor position by using a double row or a transosseous equivalent to suture bridge technique. If we see first group who are changing the suturing technique, they came with Mason Allen. Those who tried to start to medialize the footprint area, they started, in spite of getting this anchors here, they start to get the anchor more medially. And this is the repair technique changed into a double row repair, popularized by Burkhardt et al., where the lateral row has been put and the medial row anchor are put, and two different area has been tied. Or the transosseous equivalent, where the tension help is used to help the good footprint contact area. What are the modification you can see for the single row repair? They are the link technique and the single row link technique configuration. The link technique described by Atuso Endo in 2010, they showed that by using two anchors and using one loop, they're using the same one row of the anchor placement, we can get a two double row equivalent link repair, which is much more superior in the result. For the single row link technique, by using crisscross between the posterior fiber or the posteriormost suture and the anteriormost suture of the posterior anchor, we can make a good parachute-like attachment of the repair. Another parachute technique has been depicted by Dr. Luis Natera et al., which shows two components. One is the side-to-side component or the convergence between the anterior to posterior fibers, and second component between two sutures to put over the posterior limb and the anterior limb. So first, these sutures, two set of sutures going to the anterior part, two set of sutures going to posterior part, they are being tied with each other. The end of these both the sutures are again tied to each other to make a good coverage area of the footprint, looking like a parachute. If we see the rotor technique of the suturing technique, first given by the Gerber et al., this is a Mason-Allen technique modification. This is the way how you do the Mason-Allen technique, which actually help to ripstop the sutures. Other method has been modified after that, including using two different set of sutures, one to be tied like a horizontal anterior to posterior, another to be tied over the mediolateral to prevent the ripstopping of the suture technique. Another method described by Patrick Dennard et al., showing using a separate fiber tape to use to horizontal ripstop and the other fibers to make a proper tear repair technique. Double row ripstop technique is now popular, which uses two set of different anchors, making four different suture cuff bite over by using all the sutures. And again, after that, using one set of suture to use a horizontal repair and a set of suture to using the mediolateral repair technique. Next popularized thing, the double row repair technique proposed by Burkhardt et al., who used a medial row anchor and the lateral row anchor. The problem is that it is not economical, it has a high cost and the high operative time. It crosses approximately 4 to 5 knot over the surface, which is not good for the tendon biology. And the medial anchor and lateral anchor is not able to make the synovial fluid seepage less after the repair. So gradually this technique, original technique conventional technique has been winds up, and then we jump over the transosseous equivalent repair technique. That is first introduced by Park et al. The advantage over this technique are it improved the pressurized contact area and the mean footprint pressure, which enhance the healing. It brings the medial mattress knot flush with the tendon, which avoid the edge instability. It does not rely on the lateralmost aspect of the torn tendon because the bites are mostly taken at the medial healthy tissue. So it's give a better musculotendinous tag. It maximizes the footprint contact, and the transosseous equivalent repair is interconnected to each other, hence is a load sharing and the less theoretical chance of re-tear. This is the initial picture that's depicted by Park et al. How the anchor should be positioned for the medial row and tension by the lateral row. The modification of this techniques comes in the speed bridge technique that has been popularized by various doctors, particularly Dr. Peter Millett. They have shown how this same principle is used by using two medial row anchors and two lateral row anchors to get a crisscross, probably knotless repair technique. This speed bridge, why the knotless we are going? Because as previously discussed, the knotless gives a better, theoretically less vascularity hamper over the knotted technique. Although the largest series by using speed bridge by Dr. Millett only over 155 cases, he concluded that both the knotless and the knotted technique gives an excellent but same outcome, although the knotted technique has a higher chance of getting a full thickness rotor cuff tail. Advantage he has been given that it improves the stability and the strength of the construct by using fiber tip. Fiber tip, as it is biomechanically more stronger than suture, then gives a better hold to the tissue. And the knot slides more easily by using a cannula without the worry of entanglement of the suture. But the disadvantage of using a suture tip is that they does not slide as well as the suture in the eyelet region because of the increased diameter. So if we compare the literature between single row, double row transosseous technique, there are multiple, near about 100 literature there comparing the different technique. Some are doing at the biomechanical level, cadaveric level, or some in vivo level. Most of the literature says that the biomechanically or the cadaveric study shows that transosseous is better than double row is better than single row. But none of the study was conclusively in vivo able to produce that superiority of the particular technique. Like this Homans et al.'s meta-analysis, this is the first meta-analysis showing approximately using 100 of articles. They were not able to observe any difference in vivo technique between this different repair technique. Transosseous and single row, although they show the same result. If we come the clinical result over the patient by the transosseous and double row, and the transosseous equivalent and the double row, there is no long-term study still exists. And there is the scope of research, further research is there. So if we concise the whole idea of the row technique, single row is economical. It gives a short operative period suitable for the small and crescent shaped tear. But footprint coverage is in query. Large footprint area cannot be covered properly. So the massive tear or the large tear, it is probably not very much suitable. Double row relatively costly, operative time is more, the learning curve is very steep, but it provides the comparatively better footprint coverage, probably superior in vivo, but cannot be conclusively told, suitable for a moderate to large tear. TOE is a knotless and knotted, both are effective for all type of tear. Probably the best between all these three techniques, but again, we have to wait for the result. This is the cutout taken from the Parks published article showing the different method that can be used depending on the size of the tear. Less than 25% small tear single row, less than 50% single row or a double row transist equivalent, less than 75 or 100%. He has give immense pressure, he have given immense support with the transosseous equivalent technique by using 2 or 4 suture pitch technique. A take-home message will be the utmost important is not the method of the repair. It is the tissue and the bone quality, tear size, the mobilization of the tissue, and the maintain the biology of the tissue and the bone itself. With the idealistic situation, we have to get a high load to failure repair on the day one with a moderate tension, not exceeding too much, which gives a not less and provide a better vascularization of the repair area. Although there is no conclusive evidence on superiority of one technique to another is present. Thank you, sir.
Very good talk, Jitsan. I think you have understood the concept of optimizing rotator cuff repair very well. So this is a very comprehensive overview of how to approach any case of rotator cuff repair. This is a fantastic presentation. Kindly, if you don't mind, share this PPT to everyone. Very important.
Okay, sir.
Now,
Okay.
whatever you mentioned is more than enough. I don't have to add anything to the comments. So just to give a brief discussion of how we approach any case of rotator cuff tendon tear is arthroscopically. No, preoperatively we know how to assess. Okay, we know all the prognosticating factors. But arthroscopically, when you go, sometimes you may get a surprise because first thing that you will not be able to assess is the quality of the bone. So invariably, the best method of fixing a rotator cuff tendon back to the bone is transosseous technique. So there is no replacement to it. Whether it is open technique or arthroscopic technique, transosseous repair confers the best possible footprint contact so far. So that's the reason why we are more or less switching towards transosseous technique right now in an arthroscopic way. But what has happened is with the single row repair, previously, that is before the advent of the transosseous equivalent technique, when the double row repair was available, this single row was used even for the massive and the large tears. And that was the reason it failed, because it was not conferring a good contact pressure onto the bone. And that's the reason why the single row repair was less in favor, and they switched over to the double row repair. But the problem with the double row repair is the presence of knot, and these knots were present in a very poor quality tissue. That was the reason for failure. See, definitely a double row repair is better than a single row repair when it comes to a large tear, large or a massive tear, because it makes sure there are multiple points of fixation of the tendon onto the bone, and make sure that even if one point fails, the other point makes sure that the tendon is retained. But the problem here is these double row repairs were having multiple knot points, the presence of knots, which creates a weak link, and the tendon may rip through, or the suture may cut through the tendon when the tendon quality is poor. And that's the reason why they started using the transosseous equivalent, because in the transosseous equivalent, the crisscross sutures make sure that the footprint contact is much better onto the GT. And that was proven to be biomechanically proven to be better than the double row repair. But what happened here was the presence of transosseous equivalent. Even in those cases, using the knot in the medial row led to a weak link. So it resulted in Sugaya type 2 retears. Okay, so that is the reason why they switched over to a fiber tape configuration without any knots onto the medial row. This is the problem where the problem started. So this became extremely commercial. So what happened? Already using a double row transosseous equivalent technique means 4 suture anchors, costly. Second thing, using a fiber tape in the place of fiber wire. So there was a lot of commercialism involved in this type of repair, and all the conferences you see, they were using this particular type of repairs. As you know, conferences sponsored by the companies. So they would want to show their anchors, their type of fixations, all those stuffs. And invariably, all the people who are starting to do the shoulder arthroscopic surgery switched over to this type of repair because more anchors used, more fiber tapes used, commercially good for the companies. But ethically, it is not right. Okay. So you have to assess what type of cuff repair needs what type of configuration. So how we approach, first thing is the moment we go inside, we assess whether the cuff is reducible or not, and then check on the thickness of the cuff, whether the cuff is pliable and the thickness of the cuff is adequate or not. That is first thing. Second thing is how to reduce. Okay, you have already mentioned if the cuff is reducible, it's good. If it is not reducible, you have mentioned the supraglenoid release, the subacromial release. All these releases will ensure that the cuff comes back to its GT without any tension. So a tension-free repair. Third thing is, if a cuff is coming back comfortably onto the GT, a single row repair is more than enough. Okay, and here in the single row, there are many techniques which are available, which are equivalent to a double row repair, which means you can use the ripstop stitch configuration, or even you can use a parachute technique, which ensures maximum footprint contact. Only if the quality of bone, which means when you're trying to insert the anchor, and if you feel that the quality of bone is poor, you either switch over to a transosseous repair or a transosseous equivalent technique, which is in the form of a double row transosseous repair technique. But that's where you have to make sure that in a transosseous equivalent technique where you use the medial anchor and the lateral anchor, you have to use knots. Why? Because in an osteoporotic bone, the GT is extremely weak. So the strongest part of the proximal humerus in such scenario is at the articular margin, that is at the subchondral bone, which is in the medial row. Once you put an anchor over there and take the bite through the tissue, make sure you put a knot and make sure that that part of the cuff is connected to the medial row as much as possible. Because when you use the lateral row anchor onto the lateral cortex of the GT, which is a weak part of the bone, it may rip through anytime. And here is where your decision making is very important. And in this case, you have to use a medial knot to make sure that in case the lateral row fails, the medial row is there to hold the tissue back. Okay. So, but we are extremely lucky that we have the transosseous tunneler. So if we come across any osteoporotic bone, this transosseous tunneler with the help of a fiber tape is much more good enough compared to the suture anchor technique and ensures a good footprint contact. So on the whole, first assess the bone quality, then check on the reducibility of the cuff. If it is reducible very well, in the presence of a very good bone quality, a single row is good enough and economical. In the presence of a bad quality cuff tissue, or in the presence of a irreducible or difficulty reducible rotator cuff tendon, or in the presence of a weaker quality bone, then we have to switch out to a double row technique. Or if you are good enough to have a transosseous technique is much better.
Thank you.
Very good talk, Jit. And you gave a nice talk on everything you need to know about cuff repair at one shot. It is really good. And only thing I'm surprised that you never mentioned about Snyder. See, Steven Snyder is the one who, all this earlier on, if you see any post-op X-rays, when only the metal anchor was there, sometimes you see 8 anchors, up to 8 anchors. One of the demos that we had, and if I remember correctly, I can't remember, at least about 6 anchors were used, metal anchors for a single patient. That's how it was. Now we know that depending on the type of tear, you use a minimum anchor such a way that you could get good coverage. Snyder is the one we've been time and again have been talking about biology. Whatever it is, or single row, double row, toe equivalent, all that, unless you prepare the biology, prepare the bed nicely and make it bleed, and it may not heal. So all the techniques are good, they're evolving, but do not forget biology. Thank you.
Thank you, sir.
Good morning, sir. I'm audible.
Yeah, you're audible. You're visible.
Good morning, everyone. My talk is on the mini open rotator cuff repair.
Just unshare the screen and then you can just unshare the. Share the screen. It's a mute.
What happened?
Amar, you're not audible. Probably is not aware.
Am I audible now, sir?
Yeah, I can increase your volume, mic volume.
Is it, am I audible, sir?
Yeah.
So the screen is hung up. I'll just get back in. Am I audible now, sir? Am I audible now, sir?
Yeah, go on, go on.
Sir, sorry for the glitch. So my talk is on mini open repair. Why is it important in the era of arthroscopy repair? As you know, India is a big country and not everyone can learn the art of meticulous arthroscopic repair. So it's always good to have a alternative technique which is which has a less which has an easier learning curve than the arthroscopy. As you all know, it has a slight difficult learning curve. So the fundamentals of the open rotator cuff or the mini open were described by Neer in 1972. That meticulous repair of the deltoid origin, if the deltoid, as in the open case, is detached, it is important. The subacromial decompression, then the surgical release to obtain a freely mobile musculotendinous units, as already described in the previous talk, and a secure transosseous fixation of the tendon to the tuberosity, and a supervised rehabilitation program. So what is this mini open? One of the earliest studies done to describe the mini open was by Howard J. Levy, and he described it as an arthroscopic assisted rotator cuff, which means that starting in the beginning, there was the diagnostic arthroscopy was done. Then the subacromial decompression and the acromioplasty was done with the help of arthroscopic instruments, and then the final cuff repair was done through a deltoid incision through the deltoid. He did it on 25 patients, and he attained a satisfactory rating and a significant improvement of pain, function, and motion in 80% of the patients. Another study done on the mini open repair was done by Roger G. Pollock in New York, and he again described it as an integration of arthroscopic and open methods. And he did the study on 30 patients, and a follow-up was about 25 months, and he received excellent results in all the 30 patients. What are the important points to keep in mind? The first and foremost is the exposure or the approach. Second is identifying the cuff and its anatomy and the anatomy of the tear. And the third is the repair technique. So three incisions have been described in literature for the mini open repair, the most common ones. First, the commonest is the lateral port excision. It's just the distal and proximal extension of the lateral arthroscopic port. The second is the coracoacromial incision between the lateral end of the acromion and the coracoid process. And the third is the anterolateral incision. It vertically downwards from the lateral lateral end of the clavicle. So in the lateral portal extension, the fascia or the deltoid is split more or less in the middle fibers of the over the middle fibers of the deltoid. In the coracoacromial, it's almost between the anterior and the middle, and in the anterolateral, it's detached. The anterior fibers are open. After the detachment of after the splitting of the deltoid, the subdeltoid portion of the bursa is identified in all the three approaches similarly, and it is opened to reach the cuff. The anterolateral approach theoretically is better for the anterior, the tears which are more in the anterior, whereas the coracoacromial lateral port was described for all the tears, and the tears were reached or identified better by the rotation, internal and external rotation of the humerus. This was a study done on the mini open approach, the coracoacromial approach by Wolfram Thomas, and he described certain advantages. He said that the coracoacromial approach, there is a simple operative handling. It's easy to perform, and the surgical time is less. And since it's more along the Langer's line, so it has a satisfying aesthetic result. And he did not report any re-tear due to the cutout of sutures or anchor insufficiency. The disadvantages, as with all the mini open and open repair, is a relative risk to the axillary nerve, and as it is with all the repairs, the quality of the tendons. So if the tendon is large and the tendons are retracted, then the incision might have to be extended, and we might need to convert it into a open approach. This is the study on the anterolateral approach. It was done by the Korean surgeons. They did this approach in about 128 patients and had excellent results in 71 patients and good results in 39. And they had about 8 patients in which the results were not as expected. And they did not find any correlation between the American Society of Elbow Surgeons score and with the age, the symptoms, and the size of tear or the duration. Now, the most important point in this mini open and open approaches is the deltoid split. And there have been a lot of studies describing the adequate length of the deltoid split. And this was a review done in the United Kingdom by Sevaramanbi and Gulihar et al. In the Glenfield Hospital, Leicester. And they described a range of about 4.5 to 6.5 centimeters. And they also compared it with other studies. What conclusion they got is that the mean nerve distance in neutral position was 6 centimeter with a standard deviation of 0.6, and that the nerve, the arm position from neutral to 10 degrees increased the nerve, and moving the arm position in abduction decreased the distance. So what they concluded is that using the traditionally recommended, textbook recommended deltoid split of 5 centimeter is risky, and they said that a maximum deltoid split of around 4.2 centimeter would be safe in about 99.7% patients. When the cuff anatomy is not better understood, then we don't have a choice but to just release the origin of the deltoid from the anterior edge of the acromion, and this is more can be more easily done in the anterolateral as compared to the lateral portal and the coracoacromion. Another important point of the mini open or cuff surgery is the acromioplasty. Theoretically, acromioplasty it reduces the critical shoulder angle. Critical shoulder angle is the angle between the line joining the superior and inferior part of the glenoid and the line from the inferior part of the point of the glenoid to the lateral edge of the acromion. And this acromioplasty significantly reduces this. And what is the role of the critical shoulder angle is that it has been proposed that it is associated with re-tear. So patients who have a higher critical shoulder angle have a higher chance of re-tear and shoulder osteoarthritis. Another study done more recently done in about in 2021. It was a retrospective cohort study involving 1,320 patients. They, on the other hand, found no difference at 6 months, especially when it comes to the level of shoulder stiffness over at activity, pain, or moving the shoulder behind the back. This study basically showed no additional benefit of acromioplasty. Another important step in this surgery is a bursa excision. So bursa excision is very important to better see and appreciate the cuff. And in an open technique, the finger is used to identify the plane between bursa and cuff, and it can be held with a small nibbler. And in an arthroscopic technique, it is removed with a bar. This is an interesting article published in 2022, and it shows that subacromial bursa may possess mesenchymal progenitor cells. So the authors described that to maximize the chance of healing, it would be better to avoid excising the bursa tissue, unless it is obviously necessary to aid in the visualization of the cuff tear. Next step is identifying the anatomy of the tear, which has already been described by Dr. Jits in detail. So we have to identify whether the cuff is a crescent tear, L, or a reverse L, or a massive tear. And depending on that, we have to plan the fixation. This is the crescent tear, the reverse L, and as already described by Dr. Jitson, the initial strategy is, if it's a complex tear, difficult tear, to convert it into a simple tear. Now the fixation techniques. The suture anchor technique has already been described in detail by Dr. Jitson. I'll be talking about the transosseous technique because it is the traditional, and as Shams already said, that it is the strongest technique, and it's being used increasingly now. There are different instruments that can be used for the transosseous technique. The traditional ones are bone needles and the bone hooks. Then there is the arthrotunneler, even simple K wires, the ACL guide, and there's a new device called as the Shark FT device in Moderna, Italy, and this has also been used for the transosseous technique. This is the study done in 1997, and it basically described the strength of fixation of the transosseous sutures. And they gave that the strength can be increased by placing the suture at least 10 centimeters distal to the tip of GT, and by tying them over a bone bridge that is at least 10 centimeters apart. They also proposed that when the bone is very osteoporotic, cortical augmentation with a readily available button can be used to strengthen the repair. This is the arthrotunneler device, devised by Arthrex. The first step is obviously to make the drill at the site of the proposed entry, and it's at the subchondral bone just next to the articular cartilage, as we discussed. Then is to insert the hook of the arthrotunnel into the medial tunnel, and then the nitinol loop is deployed through the tunnel, and the 2.5 drill is inserted through the lateral through the loop of the hook, and then the suture inserter is put to deploy the suture, and the suture is retrieved from the other end. And the repair can be done by passing the suture through the cuff, and this can be used either as a definitive suture, or it can be used as a shuttle to pass multiple sutures. Depending on the length and the geometry of the tear, other additional tunnels can be made to fix. This is the lateral implant called as a tunnel pro, which is used in addition along with the transtunneler. It basically protects the suture bone interface It reduces the possibility of suture migration. It helps in equal distribution of the stress over compared to the suture region alone. And it reduces the bone abrasion. This was a study done using the transtunneler, arthrex transtunneler, and they described something as an X-box technique. Basically, the suture configuration was in the form of a X inside a box. So they described the advantages of using the transtunneler and the lateral screw. They said that there is a favorable pressure distribution, and there is a high blood flow provided by the bone tunnels, and it has a lower cost than the suture anchors, and the operating times were equal, and it can be easily learned by the person who's already well versed with the art of surgery. This is a new device that has been used in Italy and introduced by Dr. Andrea Pellegrini. This it's called as the Shark FT, and it utilizes an instrument called as the Taylor stitch. So it's similar to the transtunneler, but instead of the peak material screw, they have this Shark FT device to be placed on the lateral cortex. So after making the tunnels, they use the sutures are pulled through the Shark FT device, and into this this device is placed on the lateral wall. And this was an article published in Turkey, which the surgeons used this Shark FT device, and they had a caseload of about 91 patients, and in the final follow-up, they found that the scores had significantly improved in this repair, and there was no difference between the small, medium, or large size tears, and it significantly improved the functional and clinical scores. However, they also mentioned that long-term studies and larger groups and multi-center trials are important to confirm its efficacy. Finally, coming to the few slides on the comparison between the arthroscopic and the mini open cuff repair. This was a study done in 2015. They reviewed 5 RCTs, did a meta-analysis, and including 166 patients of the arthroscopy group and 163 patients in the mini upper group. They found that there is no difference in surgery time, functional outcome, VS scores, and the range of motion between the arthroscopic and mini open technique. And also there was no significant difference in the pain scores in early phases. This was done in 2017, and again, they concluded, on the other hand, that integrity of the repair and function were better in a mini open repair, and mini open repairs is a good alternative despite advances in arthroscopy techniques. Although their case number was a little less, it was only about 22 in mini open and 128 in arthroscopy. And this is the recent meta-systematic review. It was published in 2021, and they concluded that patients undergoing arthroscopic repair for rotator cuff tear had an improved outcome as compared to the mini open repair, and the modern arthroscopic double row repair has a similar strength as compared to the similar failure rate, as compared to the open row techniques. There are other papers also, but most of the papers are very ambiguous and they don't give a very clear-cut superiority of one or the other. So the take-home message is that it is still a very good alternative. The good point about mini open as compared to the open technique is that the origin of the deltoid is preserved, which helps in post-op rehabilitation. Again, we have to be very careful about the axillary nerve and the length of the deltoid split. Identifying the tear anatomy and releasing the tear is releasing the tendon is again very important. And repair techniques can be transosseous, or even suture anchors can be used through the open technique. And the rehabilitation, which is a difference from the open technique, is that the rehabilitation in mini open is similar to the arthroscopic cuff repair. Thank you.
Thanks, Amar. Now, see, the take-home message as far as mini open cuff repair is concerned is, it is on the long run, when you compare the arthroscopic rotator cuff repair with the mini open cuff repair on the long run, that is more than 1 year time, the outcome is more or less the same, which means the patient's functional activity is the same, shoulder power is same, everything is fine. Only difference is when you do a mini open cuff repair, the recovery period is longer compared to the arthroscopic cuff repair. So we have to be careful when we choose this procedure for which age group, and we have to clearly prognosticate the patient. In Indian scenario, there is a very important role of this technique because it is very economical. The surgery, let it be whatever type tear configuration it is, you will be in a position to finish the surgery within 30 to 40 minutes time, which may be difficult for a beginner to do it arthroscopically. Now, but there is a fantastic scope for us to understand the tear geometry, the biology, and the tear reducibility with this technique. So when you're starting your career as a shoulder surgeon, always start with the mini open cuff repair technique, understand the biology, how to reduce the tear, and then you can gradually switch over to the arthroscopy assisted mini open cuff repair, and then to complete arthroscopic. There are two things which we may have to keep in mind. One is, when you're doing arthroscopy and then switching over to the mini open cuff repair technique, try to do all the bursectomy, subacromial and the subdeltoid bursectomy arthroscopically, and release only or take out the bursal tissue only how much it is needed. Which means when we are doing the cuff repair, we take the bursal tissue up to an extent where we are going to take the bite through the tissue, because I need to see the bite, I need to see the knot. That's all. So take only what is needed and don't completely take it off like how it was done earlier, because now the bursal tissue acts as a very good source of mesenchymal stem cells and a vascular channel which will help aid in the cuff repair. Second thing is, in cases where you come across impingement syndrome and prolonged or hook-like acromion causing reduction in acromial space, you may not be you will not be in a position to preserve the deltoid and do a subacromial decompression or a acromioplasty. If you want to do an acromioplasty in a mini open technique, it is imperative that you have to release the deltoid. So that may not be good for the deltoid healing and recovery. So try to do those things arthroscopically, that is acromioplasty and subacromial decompression, how much ever is needed. And then once you open up, what you have to do is just split through the raphe, just split the muscle. You'll be able to see everything. And I will always try to do a transosseous repair when I do a mini open, because that is the best fixation technique available, and it is easy to do as well. I don't use any implants. And all these implants which are mentioned in the transosseous technique, like Pellegrini, I mean, I don't know, because see, you have a fantastic bone. Okay, what else do you need to secure the fixation? All that you need is a very good fiber material to fix the cuff back, and you don't need any additional supplements to enhance the repair. So this becomes very commercial, and it doesn't really serve the purpose of a transosseous repair. So whatever transosseous repair, just a fiber wire or fiber tape through the bone and properly knot it over the tendon, that's good enough for a fantastic healing. So start with a mini open, protect and preserve the deltoid. That is very important. Do not damage the deltoid. Then switch over to arthroscopy assisted technique, and then to arthroscopic technique.
All right, sir. Thank you.
Good message, Shyam. A lot of our old fellows are there. And any of them want to say anything? Any comments? Nobody. Okay, it doesn't matter. So as Shyam said, whatever you do it properly. Go gradually, and that's a very good take-home message. Gradually, mini open, then arthroscopy assisted subacromial decompression, and then cuff repair. Thank you.
Thank you, sir.
Thank you.
Good morning, sir. Sir, am I audible, sir? Is my screen visible, sir?
Yes, Shashi, go on.
Sir, good morning, sir. This paper has been selected for gold medal presentation, sir, podium presentation for IOCON 2022, sir, which is being held this week in Amritsar, sir. So the time limit is 10 minutes, sir. So I just want to present it once before for your valuable feedback, sir. Thank you, sir. I'll go with the presentation, sir.
What is time given for you?
10 minutes, sir.
Is somebody timing? Can somebody time, please? Jit, can you do the timing? Go on, go on.
Good morning, all. I'm Dr. Shishidhar Nara. I'm pursuing my fellowship in spine surgery from Orthoban Orthopedic Specialty Center, Coimbatore. I would like to start by thanking all the organizing members of IOCON 2022 for giving me this opportunity for a podium presentation. I would also like to express my gratitude to my senior consultant spine surgeon, Dr. Sriram Lingam, for allowing me to share this technique on this very platform on his behalf. As we all know, ossified ligamentum flavum can only be treated surgically, and conservative management has a minimum to no role, and surgical management has high complication rates. As per literature, the dural tears mount about 18.4%, CSF leaks 12.1%, infections 5.8%, and neurological deficits to about 5.7%. The objective of our study is to analyze the safety and efficacy of a newer approach on excision of ossified ligamentum flavum. It's a prospective study. The study was conducted between 2020 to 2021. 5 patients were included in the study. Out of 5 patients, 2 patients had ossified ossification at 2 levels, that is both thoracic as well as lumbar. And among them, 4 were females and 1 was male. The average age was 57 years, and 2 patients had associated diseases like dish and ochronosis, and the average duration of symptoms were 21 months. And coming to the commonest level was between D10 and D11, and the patients who presented with both thoracic as well as lumbar involvement were neurologically worse. Coming to the classification of ossified ligamentum flavum is a Sato classification, where he classified OLF into lateral, extended, enlarged, fused, and tuberous type. Coming to our profile of our patients, 1 had extended type, 2 were enlarged, 2 were fused, and 2 had tuberous type. Radiological dural ossification was present in 3 patients. For functional evaluation and outcome, Japanese Orthopedic Association scoring system for thoracic myelopathy with a total score of 11 and least score of 0 was taken into the account. We have also included the Ospesity Disability Index as well as Asia grading. Now coming to the surgical decompression options, there are various surgical decompression options, and we would like to place our technique between en bloc laminectomy plus dural excision leaving arachnoid, and laminectomy plus floating ossified dural matter. Our surgical technique is based on 2 principles. One being the narrowing of the thoracic canal, or the ossification starts from the capsular portion and progress medially as shown in the axial cuts of CT image down below, and the absence of the yellow ligament at the level of pedicle as seen in the sagittal CT cut. Coming to the surgical technique, after a wide exposure is made, pedicles are marked and pedicle markers are inserted. Once the position is checked, the pedicle markers are removed and the holes are plugged with the bone wax. And 2 horizontal gutters are made, complete horizontal gutters were made above and below the desired pedicle level. The gutters extend from medial wall of the pedicle to the medial wall of the opposite pedicle. And then two vertical gutters are made extending from the lower inferior wall of superior pedicle to superior wall of inferior pedicle, as you can see in this image. And the vertical pedicles lie very lateral to the over the facets and lateral to the spinal canal, thus creating a safer corridor. And a very lateral corridor of entry is possible vertically. The horizontal corridor of entry is above and below the flavum. After that, the vertical gutters, the bone, the inner laminar cortex is burred out, thinning it completely. And as you can see in this image, the schematic diagram shows after the thinning of the vertical gutters into paper thin width of paper thin width, which act as hinges while everting the ossified mass. And midline entry is the spinal canal is entered through midline, and both ossified fragments are everted from medial to laterally using a pen-filled dissector. And as you can see in the image, a complete decompressed thecal sac is achieved. And following that, pedicle screws are placed, and the dura is covered with an abgel. Neural monitoring was done in all the cases, and no intraoperative signal drop was seen during the procedure. Coming to the results, the average JOA score for thoracic myelopathy, which was 5.2 preoperatively, has improved to 9.6. That is the increase from 47% to 87%. And the Oswestry disability index, the average pre-op was 74.2, has significantly reduced to 24. And coming to the neurological status, two patients who presented with Asia D preoperatively has improved to Asia E postoperatively, and one among two patients who presented with Asia C preoperatively has improved to Asia E and Asia D, and one patient who presented with Asia B preoperatively has improved to Asia D, which showing a good neurological recovery. Coming to histopathological analysis, all our samples did show fragments of dura. Coming to my first slide, this technique can possibly reduce the complication rates like dural tears, CSF leaks, and neurological deficits. Coming to the limitations, the resection of the facets is to be done. Transpedicular screw fixation is needed. The dura cannot be preserved completely. Dural component was present in all histopathological reports, although no CSF leak existed. These are the cases on which we have performed. This is a case of D10, D11 enlarged type of OLF, pre-op and post-op images, as well as the patient's rehabilitation can be seen in the picture. And this is another case with two-level OLF, dorsal as well as lumbar fused type. As you can see, the intraoperative images and post-op rehabilitation protocol has been going on, and the patient is doing fine. This is a patient with dorsal OLF with ochronosis. As you can see, the intraoperative image where the deposition of homogenesic acid and pre-op and post-op images. Coming to the last case, patient with OLF at two levels, dorsal as well as lumbar. As you can see, the pre-op and post-op images, and patient is doing fine. Coming to the conclusion, the approach of creating wide lateral gutters and everting the ossified mass may be considered as an alternative in the management of ossified ligamentum flavum, along with other approaches to reduce the complications. This is a tabular column showing the various percentage of complication rates of dural tear, CSF leaks, neurological deficit compared to our technique. These are my references. Thank you.
10 minutes.
Yeah, excellent timing, Sashi.
Thank you,
And it was really good. I'm sure you will win the medal. All the best.
Thank you, sir.
And a few rehearsals, 4 or 5 times rehearsal, and replay it and listen to it. Then you can, you're pausing a lot of times, and that can be reduced. I'm sorry if I was not attentive. So in the beginning, you said it's a new technique.
Yes, sir.
Did you highlight the new technique?
Yes, sir. The surgical procedure is a technique, sir, in which, I mean, how the ossified mass is being excised. The approach to the ossified mass is a technique, sir.
How is it different from existing technique?
Sir, existing techniques have sir, existing techniques include the en bloc resection and with dura excision. Those concepts, we would like to reduce the complications by mostly preventing the dural tear, sir. And usually, the ossified mass is removed by pulling off from the dura, sir. But here we are dissecting the dura from the ossified mass, separating the dura from the ossified mass by slowly dissecting, sir, rather than uh, pulling off or lifting it up.
You have a separate slide for that, or this is what you said in your talk, or somebody.
Yes, sir. This is the intro picture of dissecting the ossified mass from the dura, sir.
Yeah, I know. In the talk,
Sir.
are you in a slide saying this is existing technique which is got a lot of complication, and this is a proposed technique which is? Are you highlighting it?
No, sir. Actually, there are plenty number of techniques, sir, with a lot of modifications in this. So,
Shashi, go back to the slide which shows the techniques. Laminectomy, laminoplasty, and
sir, these are the techniques of surgical
Oh.
depression.
yeah.
See, for you to win the medal, you have to tell them, listen, I mean, this is the existing technique, this is our new technique. And where and which slide conveys this?
Sir Sriram, sir. Sir, these are the techniques that are existent, sir, already.
Yeah, I agree with you. I understand you are explaining all this to me during the talk.
Sir. Idile pota poduma, sir, or
but mention it. So
okay,
that the judges will wake up. Okay, this is new.
Okay, sir. Okay.
I don't know whether I'm demanding too much or not. I don't know.
Healing, sir. Like we will. So how is our technique different or a separate slide put, sir?
Then you will get more marks. Okay, this is new. You know, the judges may be thinking of something else.
Yes,
they are giving the marks.
Okay.
There should be a wake up slide for them.
Okay.
Okay, sir.
Good otherwise. All the best.
Thank you, sir.
Shashi, Santosh here. Previous, I mean, in the starting, did you mention about the rarity of this condition? And
initially, sir.
Illa. So when they come to the numbers, they'll have the impression numbers are less. So you must convey them that this is I mean, when you tell the numbers itself, or here somewhere where if you compare with other studies which are competitors in the presentation, they might have 100 cases. So when you show only this much cases, you must clearly convey the message that this is a rare condition. And any similar studies are there?
Yes, sir. The last slide which I've put the 6 studies.
Just one passing remark, and you don't has the numbers.
Yes, sir. They in one study the maximum sample was around 22 only, sir. We have
that is not mentioned
5,
here.
Sir.
So you
yes,
should
sir.
convey the message. All other similar studies also have similar numbers because of the rarity of this condition. So numbers are less. You can mention that in the limitation also.
Okay, sir.
So you must convey that all the comparative studies are like this, and no such publications are there for this technique. And this is a novel new technique that you have to keep on telling, as sir says.
Yes, a very good point. Very good point.
Oh, yeah.
No. Okay, sir.
So you should convey. You should not let them ask this question that your numbers are less. You should tell them that these numbers are less because of the rarity of the condition. And other point is novel technique. What other thing is important in this? So, I mean, being in the spine, you're not really sure. Anything which is new or something interesting in this, which can be brought about also, has to be highlighted better. So even in your cases, you should variety of cases. Go back no, 2 slides. Your conclusion also, come to the conclusion, it should be in points rather than a sentence. It can be as creating wide lateral gutters, averting the ossified mass, and something like points rather than a sentence.
Okay, sir.
It will convey the message quickly to the listeners and judges. And the previous slide, 2-3 examples, case examples which you showed, no?
Yes, sir.
Too many pictures. You talk through all of them. But when somebody sees this, they'll get confused which one to see. So when you talk about the first, go back to the previous slide. This is ochronosis, no?
Yes,
So
sir.
you first show the CT image first, then in an animation, you make the second image appear when you're talking about ochronosis.
Okay,
And the next image as post-op, and the next image as the walking video. Don't put all the images at one shot.
okay, sir.
So that the viewer is always glued to your screen. They keep on watching the screen. So if it's static for even 3 seconds, it won't be nice. Go back. So you mentioned case 1, 2, 3, 4. So you just mentioned case 1, diagnosis, and pictures arranged in a regular format rather than this haphazard. From left
Okay,
to
sir.
right, you can arrange.
Okay, sir.
And,
Sir, Yurajan.
yeah. Okay. One second. A lot of practice required where you stop in between and you use coming to the slide too frequently, and you pause a lot. So a lot of practice required.
Okay, sir.
Sir, Yurajan here.
Yeah. Well.
Yes, sir.
Sir, சொல்லுங்க
Sir. Sir, actually, initial introduction கொடுக்கும்போது ஒரு ஸ்லைடு வந்து you should always talk about a surgical anatomy, clear point. ஏன்னா ஜட்ஜஸ் வந்து யாரும் ஸ்பைன் சர்ஜனாக உட்காந்துருக்க மாட்டாங்க மெஜாரிட்டி ஆஃப் த டைம். ஸோ நீங்கள் ஃபஸ்ட்டு அண்டர்ஸ்டாண்ட் பண்ணும்போது இன்ட்ரோடக்ஷன் சைடில் வாட் இஸ் ஓஎல் ஆசிஃபைல் லெகமெண்டம் ஃப்ளேபம் அப்படிங்கிறக்கு ஒரு பிக்சர் மட்டும் சைடில் ஆட் பண்ண சொல்லுங்கள். ஸோ ஜஸ்ட் டு கிளாரிஃபை தட் பிகாஸ் இட் மேக்ஸ் கிளியர் தட் வி ஆர் கோயிங் டு டீல் வித் திஸ் கண்டிஷன் அப்படின்ட்டு. ஏன்னா டைரக்டாக இன்ட்ரோடக்ஷன் போகும்போது தே வில் நாட் அண்டர்ஸ்டாண்ட் வாட் இஸ் திஸ் கண்டிஷன், இல்லை டக்குன்னு போயிடும். ஸோ அந்த பாயிண்ட் சர்ஜிக்கல் அனாட்டமி ஒன்று. உங்கள் ப்ரொசீஜரில் வந்து did you face any difficulty and how was the learning curve and how feasible for a starting surgeon to apply this technique அப்படிங்கறத நீங்க சொல்லணும். ஸோ அப்போதான் உங்களோட நியூ டெக்னிக் will be validated.
Yeah. Okay.
So one more point which I would like to highlight, because all the judges, one important thing which they will think about when you're doing or explaining about a new procedure is the duration of the surgery and the reproducibility. So it will be better to mention how easy and what is the duration of this new procedure which you did, and how easily reproducible it was in all the cases. So which means it can be done by the other surgeons also comfortably, and it yields more points to your talk.
Okay. Okay. Duration of the excision oda duration evlo அப்படிங்கிற மாதிரி இல்ல surgical duration evlo போடுறதுங்களா?
Yes, the excision in the technique, this technique's duration.
Okay.
Sir, is there any comparative இந்த டெக்னிக்குக்கும் மெத்தடுக்கும் ஏதாவது உங்களோட சீரீஸே இருக்கா சார்? Like
இல்ல
doing this modified technique with conventional technique, did you find any difference? அந்த மாதிரி இருந்தா இன்னும் கொஞ்சம் பெட்டரா இருக்கும். ஏதாவது கம்பேரிட்டிவா அது மாதிரி எல்லாரும் லிட்ரேச்சர் இருந்தாலும் யூ கேன் கோட் எனி லிட்ரேச்சர்ஸ் கம்பேரிட்டிவ் ஸ்டடீஸ்.
இது வந்து so far இல்ல சார்.
இல்ல.
so far described technique எல்லாமே வந்து end block resection தான். So end blocker they make gutters or something, and they நிறைய விதமா they use a kerosene ronjare தான் actually or burr and make an end block kind of thing, and then dissect it out from the remove it end block. Then the chances of dural tuck and CSF leak is extremely high. and they always try patch it with the dural patch and the flow seal எல்லாமே. In our technique, we go through the midline and then dissect it from the midline out. Not an end block thing. We keep the lateral gutters intact so that they act as a hinge to open it out. அதனால இதுல வந்து நமக்கு dural tear இல்ல. But ஆனாலுமே all the histopathological analysis has shown some component of dura in that, which means that some dura is definitely adherent to the bone, but we don't get a CSF leak or a dural repair is not needed.
ஓகே சார். ரெஃபரன்சஸ் மட்டும் ஏதாவது நல்ல ஒரு ஸ்டாண்டர்ட் லிட்ரேச்சர்ல இருந்து ஒரு 2 ஆர்டிகல்ஸ் காமிக்கிற மாதிரி போடுங்க சார். அதோட ரிசல்ட்ஸ் எனக்கு ரெஃபரன்சஸ் ரொம்ப க்ரௌடா இருக்கு இதுல.
ஓகே ரெஃபரன்சஸ் வந்து ஓகே அந்த லாஸ்ட் ரெஃபரன்ஸ் போடுற ஸ்லைட தவிர வேற 2.
ஆமாங்க சார். ஒரு இதுல அதாவது மோர் ரெலவென்ட் ஆர்டிகல் டு திஸ் யுவர் ஸ்டடி, அதை மட்டும் அவங்களோட எந்த ஜேர்னல், அவங்களோட கன்க்ளூஷன் ஆஃப் த ஸ்டடி என்ன அப்படின்ட்டு
ஓகே
ஒரு ஸ்லைட். இட் மேக்ஸ் மோர் இம்ப்ரெசிவ் அந்த இதுல.
ஓகே
So when is the meeting and when are you going, Sachin?
Sir, I'm leaving tomorrow, sir. Tomorrow, the meeting.
Oh, okay.
The Yukon is has already started, sir. Actually, 1, 2, 3, 1, 2, 3. Workshops are going on.
Right. All the best.
Thank you, sir.
Can we end the session, sir?
Yeah, please do. It's a nice session. Thank you.